Hello, good evening, everyone. Let us all start our activity with a prayer. Almighty and ever-loving Father, we glorify and thank you. You have showered us with so much blessings. Blessings many of us do not even deserve. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration so that they may share the most of their knowledge, heart, and soul to their respective topics. May we absorb the individual knowledge and put it into practice that what we may learn today. We pray that you bless all the committees in charge that they may be able to fulfill their tasks responsibly, that the objectives they have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be living witnesses of your genuine love through the enhancement of the knowledge acquired through this activity. We remember our friends who are sick and those who are getting well. Lord, we pray for them. We ask this in the name of our Lord and Savior. Amen.
Amen.
Miss natin si Agnes ngayon, ano? Pero pagaling na siya.
Society of Diabetologists. PSD's mission, the pursuit of excellence in diabetology. PSD's vision, excellence in diabetology. PSD's objective, to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment.
PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing in disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of the effort. Collaboration drives inspiration, motivation and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
Good evening once again. We welcome you to another session from PSD, and I would like to thank again the people who made this possible. We have sponsors and we have a working committee, including the current board, and that includes Dr. Baltimore, Dr. Agra, Dr. Marcy Cruz, and Dr. Fatma Chu. PSD Select 3 is where we are now. These special edition lectures evolved because of the pandemic. Sa pandemic, hindi tayo makagawa ng ating mga workshops face-to-face. So we created this learning sa internet, no, with different topics. Nakadalawang series na complete na tayo, and now we are on our third series, and our topic now is DM basics and the complications with objectives, discussing the updates on pathophysiology and management of microvascular and macrovascular complications. So tonight, no, we are going to welcome a very talented speaker, Dr. Eugene Reyes. Is going to talk about protecting the vasculature today. So he's sponsored by grant from Corbridge. And then later on, I'm going to introduce to you Dr. Maria Adelaida Bulandi, a special friend, no, who's going to talk about naman interpreting tests for the diagnosis of common PVDs in patients with diabetes. And then we'll have, after each lecture, we'll have a short question and answer. So before we start, we would like to thank our sponsor for this night's event, Corbridge Pharma, who has been with us for a long time. And they have many products. And one of the products that we are going to talk about tonight is Sulodexide. Thank you again, Corbridge, for being with us. And the speaker is not new to us. Suking-suki na natin si Doctor of Medicine from PLM, Associate Professor, Department of Medicine, UP College of Medicine. She is the head of the Chief Division of Cardiovascular Medicine at UP PGH. Is the head Healthcare Services, Manila Doctors Hospital. Scientific Advisory Board Member, Asia Pacific Society of Cardiology. At the Philippine Heart Association, is past president from 2017 to 2018. A few years ago lang pala yan. And he is active consultant at the Manila Doctors Hospital. Ladies and gentlemen, my friends, colleagues, let us welcome Dr. Eugene Ramos. Dr. Eugene Reyes. Nasaan ka na, Eugene?
Ayoko lumabas kasi mali yung pangalan.
Ay, naku, sorry. Ganyan yata pagkatapos ng COVID eh. Pasensya ka na. Naapekto na yung neurons ko.
It's always, we are always interchange. Anyway, I'd like to say hello to the members of, and thank you, Dr. Fernando, for the introduction. And I will go straight to the lecture in the interest of time. And let me share my slides to you. Okay. Nasa summary na kagad, ano? So you know already how short the lecture will be. Okay. Okay. The title is Protecting the Vasculature Today, and I'm pretty sure many of the conditions that we see every day ends up with the problems with the blood vessel. So This is my disclosure slide, and promise to be evidence-based in most of the discussion. And this is the outline of my lecture. Very important to start with the anatomical aspect of the vascular system and mention in particular an important structure within the blood vessel, and that's the glycocalyx. Uh, During my time, it wasn't being discussed in the college years. The interest came in only about a few decades ago. And then I will discuss, of course, the role of pseudodexide as a glycosaminoglycans because it is a component of the glycocalyx. And surely you will understand why a glycosaminoglycan will work in various diseases, specifically vascular disease, and will end up with data on the use of glycosaminoglycans in COVID. This is the first part of the outline, and that's the anatomy. If you notice, all blood vessels, the common denominator or common structure that you will see in all the blood vessels, small blood vessels and capillaries, is the endothelium. There are supporting structures. For example, in the artery, you have the tunica media and tunica um, external or external membrane. In the artery, in the vein, the same, you would see, but thinner muscle and also a protective layer. But when you look at the capillary, it is only composed of an endothelium, so no protection at all. So the capillaries are really delicate. And much of the data that I will discuss is the capillary. Why? Because it's it's one of the most plentiful blood component or blood structure in our body, and within the capillary is another structure that we call the glycocalyx, and you can see here in a diagram how it looks like. It's a gel type structure, sometimes invisible or invisible to our eyes. The capillaries make up approximately 99% of the total cardiovascular anatomy of the body. 99%. The aorta, the coronaries, the big arteries comprise only 1%, and majority are capillaries. And so it's very important the capillaries are healthy. But as I have mentioned, the capillaries don't have supporting structure. They exist as cells, single cells. But within, if you look at a microscope, an electron microscope or a special scope, this is the blood components in the center, and the endothelium is right there. There is an invisible structure protecting the endothelium from the blood components. And that is what we call the glycocalyx. The glycocalyx, if you look at it in a electron microscope, it looks like this. This is a capillary, and as I've mentioned, the endothelial cells is there, and there is a special layer or hair-like structures that you see composed of glycosaminoglycans and proteoglycans. In other words, sugar and proteins. That's the component. They are highly negatively charged, and they will push all components of the blood towards the center, not allowing any of its component to touch the endothelium. So in essence, it's a barrier. It's a protectant. It protects the endothelium. And the protection is universal, arterial, venous, but most especially in the capillaries. These are the major functions. As I've mentioned, it's a barrier, it's a special coating, but in addition, it releases nitric oxide that regulates blood flow. And on demand because of its connectivity along the entire system of the vascular system. They can open up or close capillaries depending on the need. For example, if I inhale um, deep inhalation, if I do deep inhalation, it will instantly open up capillaries and perfuse these alveoli for exchange of gas, oxygen, and carbon dioxide. Also, it controls coagulation. It regulates inflammation because as a blood vessel, it should not entertain inflammation because it will, inflammation will end up with scar formation, and the blood vessel doesn't want scar. It has to maintain an active layer of um, uh, glycosaminoglycans. In addition, they release vasoactive substances like, you know, um, angiotensin, endothelin, etc., depending on the need of a particular tissue. This is the drawing that I described to you. Um, the glycocalyx is the one responsible for closing and opening the needed reserve capillary. When it's needed, it can open anytime, depending on the signal that the tissue is giving to the glycocalyx. So to have a healthy vascular system, you have to have a thick glycocalyx. Now, the glycocalyx has not been known since maybe 4 decades ago, but much of it is already known. The main components are here. You can see hyaluronan, which is the one that is really lining and protecting the endothelium. And majority is heparan sulfate, which is also a glycosaminoglycan, and chondroitin sulfate. But there are other glycosaminoglycans available interspersed within all of these mesh of glycosaminoglycans. The main proteoglycan is syndican 1, and that is the one that holds all of the glycosaminoglycans, protecting the endothelium. And they are connected to a receptor called CD44 to for a stronger attachment to the endothelium. So that's how the glycocalyx is, how it is organized. Now, what damages the glycocalyx? There's a normal wear and tear. When you get wounded, the glycocalyx should shed. There is shedding of the glycocalyx. But there are conditions wherein the shedding is more pronounced than normal, and that is the presence of risk factors, like the ones listed here. The risk factors for cardiovascular disease are the ones that damage the glycocalyx. And in addition, there are several investigations wherein clinical conditions really showed the shedding of heparan sulfate, the shedding of syndicans, and the shedding of hyaluronan. These are all major components of the glycocalyx, and in these conditions, it has been proven that there is increased shedding of heparan, syndicans, and hyaluronan. And you can see them all here. There are the usual cardiovascular risk or conditions that we see in daily practice, even atherosclerosis, hypertension, and uremic syndrome. But down there, you will see that it has been seen in viral infections, and not only in viral infections, because it has been demonstrated in sepsis, bacterial sepsis. Toxins can directly damage the glycocalyx and cause, the attachment of several substances like the ICAM, BCAM, that increases the permeability of the endothelium and causing fluid loss. And with this fluid loss, it's not purely water, but rather a loss of hyaluronan, a loss of heparan, and the loss of chondroitin. And that's the reason why it's hard to resuscitate the intravascular component or bed of a patient with sepsis. In dengue, it was also demonstrated that the glycocalyx is also widely damaged. The NS1 or the non-structural one uh, uh, can modulate the glycocalyx, and even the dengue virus itself can cause direct damage to the glycocalyx and cause increased permeability of the endothelial cells. And so we see plasma leakage. And that's why we see toxic cases of dengue. And also in COVID, it was demonstrated that the SARS-CoV-2, right, once it enters the endothelium, can take over the heparinase gene. And as I've mentioned, heparinase is the one that damages or digests the glycocalyx, and that's the reason why we see widespread coagulopathy, or what we call endotheliitis in people with COVID-19. And indeed, in a recent study published, in people with COVID, the heparinase activity is very much increased. Look at this compared with healthy people. And this indirectly damages the glycocalyx. And the signal that the glycocalyx is damaged is the increased level of heparan sulfate. And there is a direct relationship between the heparinase activity and the level of heparan sulfate, confirming that COVID-19 increases heparinase activity and that the heparinase digests the glycocalyx, and may be the reason why people develop widespread vasculopathy in COVID-19. Now, is the glycocalyx measurable? Yes, indirectly. There are laboratory studies showing that the syndicans, the heparan, the hyaluronic acid, and even the glycocalyx dimensions can be measured. Indirectly, we have the inflammatory markers. Albuminuria has been measured as a sign of glycocalyx damage. In fact, in sepsis syndrome, proteinuria happens. And when the sepsis is gone, the proteinuria is reversed. So albuminuria is an indirect measure of glycocalyx damage. Also, retinal exudates, just like what we see in diabetic retinopathy, the same is a signal for glycocalyx damage. But in daily practice, all we have, the only markers that we have is the presence of risk factors. The presence of risk factors, especially long-term risk factors, is already a signal that glycocalyx has an ongoing damage and that the endothelium is unprotected most of the time. Now, what are the strategies that can protect the endothelial glycocalyx? Aside from controlling the risk factors, treating diabetes, treating hypertension, treating dyslipidemia, etc., we can avoid hypervolemia. This has been proven that, when you infuse a lot of fluid in people with sepsis, it further damages the glycocalyx. Albumin infusion, this is a negative charge protein. It can protect the glycocalyx by attaching itself also along the lining of the endothelium. Antithrombin 3, and that's the reason why the low molecular weight heparins, or the heparins, are effective. Metalloproteinase inhibitors, nitric oxide donors can also prevent damage of the glycocalyx. And of course, the supply of heparan sulfate and hyaluronic acid can. However, it did not show sustained effect until sulodexide came into the picture. Sulodexide is composed of a fast-moving heparin and dermatan sulfate. They are glycosaminoglycans similar to the structure of heparan sulfate and hyaluronic acid. The only difference is that it can sustain itself to be attached to the native glycocalyx. Now let's move on to sulodexide. As I've mentioned, it's composed of glycosaminoglycans. The same glycosaminoglycans that we have in our capillaries. 80% are fast-moving heparins, so it's a heparin by itself, and 20% dermatan sulfate. It has many roles. Number one, it's an anticoagulant. Because it's heparin, it has the same mechanism of action as unfractionated heparin and low molecular weight heparin. So consider it as an anticoagulant that is can be absorbed orally and can be given intravenously. It has anti-inflammatory action, but the anti-inflammatory action is because of its ability to attach to the endothelium or to the glycocalyx. And as such, because it can restore the glycocalyx function, it has been shown to protect the endothelium. And this is one experiment wherein sulodexide was demonstrated to reconstruct the endothelial glycocalyx. This is an electron microscope of a capillary that was damaged using a small catheter, and you can see that it is devoid already of glycocalyx. And this is the control. You can see how thick the glycocalyx is. When given sulodexide, you can see that even if it was injured, the glycocalyx became thick because of the sulodexide. In humans, it's possible to measure the glycocalyx dimension using the glycocheck. The glycocheck is like a camera that you put under the tongue, and you can be able to measure the capillary glycocalyx dimension. And in diabetes, which is a risk factor for glycocalyx damage, true enough, you can see that there is a thin glycocalyx dimension. And when you give sulodexide for a period of 8 weeks, you can see that there is thickening of the dimension. There is also evidence that it can inhibit the heparinase activity. At 5 microgram, it can reduce it by 50%. At 10 microgram, it can reduce it by 90%. And at 20 microgram, zero activity of the heparinase activity. And so it's an inhibitor of the heparinase and may be one of the benefits of sulodexide in people with vascular disease. Now, there's a lot of clinical trials which investigated the effect of sulodexide in people with vascular disease. And you can see here the different diseases in red: venous thromboembolism, peripheral arterial disease, chronic venous disease, diabetic kidney disease, diabetic retinopathy, and acute myocardial infarction. Universally, you will see that it is addressing arterial problem, it is addressing venous problem, and most especially small blood vessel, especially albuminuria and retinopathy. And in a meta-analysis, many of these clinical trials were combined together, and you can see the effect on all-cause mortality. It was able to reduce it by 33%. A cardiovascular mortality by as much as 56%, and myocardial infarction by as much as 30%, but not much on stroke. And by pulling all these clinical trials together, when you give it in people with vascular disease, this is the net effect. All-cause mortality, cardiovascular mortality, myocardial infarction, and there is no less risk of bleeding. I think this is the most important part of this meta-analysis. It was demonstrated that it is safe to be given in people with vascular disease. Many publications came in the 2019, 2020s, 2021, but the more important publication that I'd like to discuss with you is its effect when used in COVID-19. Yeah, in essence, the trial was conducted in Mexico during the pandemic, in May to August of 2020. The real hypothesis was, if you give sulodexide to high-risk people, will it protect them from getting or progressing to severe COVID? And the first 3 days of symptoms, with or without test, the patients were randomized to receive either sulodexide 2 cups BID versus matching placebo for 21 days. And the primary outcome was hospitalization, because they wanted to unburden the healthcare system, and also the need for supplemental oxygen, some levels of CRP and D-dimer, and symptoms relief. Indeed, on the second week of treatment, they saw improvement in symptoms, specifically shortness of breath. But at the end of 21 days of observation, there was a 40% reduction in hospitalization rate from 29 to 18%. And there was also a drop in the need for oxygenation from 42 to 30%. Mortality was also reduced from 6 to 2%, but it did not reach statistical significance because it was not powered for that. We have a small trial on 243 patients. It was only computed for hospitalization because they randomized high-risk people. If I may go back, these are people with risk factors, 40 years and above, with risk factors. This is the time to event for hospital admission. As I mentioned, the onset or the benefit you will see on the second week of treatment and not right away, because sulodexide is not an antiviral agent. It has no role on the virus, no role at all. It just so happens that COVID-19 caused endotheliitis and vasculopathy and vascular damage, and that sulodexide protects people from further endothelial damage. And you can see that the digression continued on until the end of the observation period of 36 days. It's a short study. So in summary, I'd like to say again, to vascular protection, you can protect the vascular system by having a thick glycocalyx. And how do you have a thick glycocalyx? Control the risk factors. And of course, there are exogenous glycosaminoglycans that is available right now in the market in the form of sulodexide. This contains fast-moving heparin and chondroitin, dermatan sulfate. And they are extracted from the same source of unfractionated heparin. First is unfractionated heparin. After further purification, you have the low molecular weight heparin, and further purification, you have now sulodexide. It can restore the glycocalyx and can return back its normal function. Sulodexide is effective in reducing events and improving outcomes in vascular disease. As I've shown to you a publication on a meta-analysis, and in a recent clinical trial, I've shown to you that sulodexide has been proven to reduce hospitalization and the need for oxygen supplementation in people with early COVID-19. Thank you for your kind attention.
Thank you very much, Dr. Eugene Reyes. We learned
Yes.
something again. We always learn something new whenever you lecture. Yan pala, dapat Dahil sa pandemic, pagka high risk, there is already a benefit pagka yung pasyente, sinisigurado natin na maganda ang kanilang glycocalyx.
Glycocalyx.
Now, I think we have time for 2 questions, Kaya
Yeah,
babasahin ko yung iba nagpadala sa akin dito ng tanong. Natanong nila, yung daw anticoagulant effect ng sulodexide. Ang ganda ng mechanisms for anticoagulation. Bakit when you compare it to heparin, ang effect niya is only about 1/50th. 1/50th lang daw ng anticoagulation effect ng heparin. Kaya actually it's very mild. Bakit ganon?
actually, if you give it orally, that's how you can compare it. And the reason is because it stays in the plasma for only few hours. And after that, they get incorporated along the lining of the endothelium. And there, it stays there for almost 24 hours. 22 days is the median, but they stay there for 22 hours. That's the average length, and they get dissociated from the glycocalyx, the native glycocalyx, for 22 half-lives. So it stays in the plasma for long. If you use the intravenous and compare the anticoagulation with unfractionated heparin, they are at par with each other. Looking at partial thromboplastin time and thrombin generation time, but not on pro time or prothrombin time.
Thank you
So
very
it's
much.
we can accept, or we can universally accept that it's really an anticoagulant.
See. Well, since ako matanda na ako tsaka high risk ako May diabetes at pag nag-COVID ako, baka mag-severe. Dapat siguro mag-maintain na rin ako ng sulodexide para maganda ang aking glycocalyx. May hypertension din ako.
Yeah.
And there is the last question here. Actually, meron pa ibang tanong. Pero isa na lang i-accommodate natin. Yung tanong niya what are the natural sources daw of foods? Of mga foods that will protect the glycocalyx. Meron ba ganun?
Meron. Actually, the source is biological yung source. So all living cells have glycocalyx. The bacteria, the protozoan, except the virus, they don't have glycocalyx. So in essence, all biological tissues contain glycocalyx. So we eat them, we digest them. The only problem is how to really concentrate them, and so that they can get incorporated into our vascular system. Now, the source of sulodexide is the intestine of pork or pig intestine. Why the pig intestine? Because they have the closest glycosaminoglycans to humans. Pinakamalapit tayo sa pig. Yung cow saka yung goat, maraming sulfur, maraming sulfate. So sulfated sila marami, and that's the reason why in the year 2000 there are people who died after being infused with heparin, because ang pinagkuhanan ng heparin was cow and goat, which is not compatible with humans. The only ones compatible with us is the porcine intestine. Yan din ang source ng low molecular weight heparin. And yan din ang source ng sulodexide.
Thank you. Buti na lang mahilig ako sa chicharon bulaklak. Kakatulong pala yun,
Pag niluto,
Mara,
wala na eh.
wala na ba? Well, thank you very much, Eugene. Salamat ng
Yes,
marami.
all the
Tatawagan ka
time.
uli namin. Nag-enjoy kami pag nagle-lecture ka. Thank you very much. And we appreciate your lecture very much. We always learn something new every time you speak to us. Thank you. And we will send you the certificate of appreciation. Salamat. And we are going directly to our next speaker. At our next speaker will talk on us about the tests test for the abnormalities of the peripheral vascular system. Si Dr. Maria Adelaida Ibulyon-T, for short, si Lenny. Len. She's a doctor of medicine from UERMMC. She's director of the Heart Institute, St. Luke's Medical City, Global City, assistant clinical professor, Department of Medicine, UERMMC, associate editor, Philippine Journal of Cardiovascular Medicine, an active consultant at St. Luke's Medical Center, QC, and Global City, Gig City. Colleagues, friends, let us welcome Dr. Ibulyon-D.
Magandang gabi po sa inyong lahat. I would like to thank the Philippine Society of Diabetologists for this gracious invitation to speak during this special edition lecture series on diabetes mellitus basics and complications. I have been tasked tonight to discuss with you interpreting tests for the diagnosis of common peripheral vascular diseases among patients with diabetes. More than 170 million people worldwide have diabetes mellitus, and this number is projected to increase to nearly 370 million people by 2030. Diabetes is a major risk factor for all forms of cardiovascular disease, which we know is the most common cause of death for adults with DM. Diabetes is also a strong predictor for peripheral artery disease, or PAD, which is defined as atherosclerosis in lower extremity arteries. Patients with both diabetes and PAD have an increased risk of adverse cardiac and limb events and impaired quality of life. In a consensus statement made by the American Diabetes Association, peripheral artery disease affects more than 8.5 million people in the United States, approximately one-third of whom have comorbid diabetes mellitus. The prevalence of PAD may be underestimated in the diabetic population due to asymptomatic nature of less severe PAD and often the concomitant diabetic neuropathy. In this table by Marso and Hayat, atherosclerotic risk factors for PAD include cigarette smoking, diabetes, dyslipidemia, and hypertension with diabetes, having a relative risk for PAD of 4. Diabetes also increases the incidence of limb ischemia manifested as ischemic rest pain or ulceration among patients with PAD. This figure is lifted from the study made by Aquino et al., and the graphs show the incidence of ischemic rest pain and the risk of ischemic ulceration in a cohort of 1,244 men with diabetes and intermittent claudication. The risks of ischemic rest pain or ischemic ulceration were significantly higher compared with men without diabetes for every level of reduction in ankle perfusion pressure. The cumulative 10-year risks of developing ischemic rest pain or ischemic ulceration were 30 and 28%, rather 23% respectively. Among patients with diabetes who have chronic limb-threatening ischemia in one lower extremity, nearly one-half will develop limb-threatening ischemia in the contralateral lower extremity within 5 years. In addition to poor outcomes, patients with diabetes are more likely to have arterial disease distal to the knee compared to those without diabetes. Diabetes is a powerful risk factor for PAD and is second only to cigarette smoking in contributing to the magnitude of increased risk. In a large multinational meta analysis, the presence of diabetes among participants in developed countries was associated with nearly a twofold increased odds for PAD. The American College of Cardiology and the American Heart Association guidelines on PAD have identified risk groups that are associated with an increased prevalence of PAD and the earlier onset of symptomatic PAD. Patients in these groups should be evaluated for PAD, and they include patients aged at least 70 years and older, those between 50 to 69 years with a history of smoking or diabetes, those aged 40 to 49 with diabetes and at least one other risk factor for atherosclerosis, and those with atherosclerosis at other sites, such as the coronaries, the carotids, or even renal artery disease. A number of risk factors that specifically influence the occurrence of PAD in patients with diabetes include the duration of diabetes, which correlates with the incidence and the extent of PAD. In the UKPD S59, it showed that each 1% increase in HbA1c was associated with nearly a 30% increase of risk for developing PAD during follow up. Diabetes appears to be more significant risk factor for females compared with males for the development of claudication. African Americans and Hispanic patients with diabetes also have a higher prevalence for PAD compared with non-Hispanic white patients, even after adjustment for other known risk factors and the excess prevalence of diabetes. Reasons for this potential racial and ethnic differences in the burden of PAD among patients with diabetes are, however, unknown. PADs are also associated with peripheral neuropathy. The most commonly ascribed symptom that develops as a result of PAD is intermittent claudication, which is an ischemic muscular pain on exertion. The pain will originate in the muscular bed and not localized to a joint. The area of the worst blood flow limitation usually subtends the site of muscular discomfort. Example, if you have pain in the hip or in the buttock, you usually attribute it to a problem in the distal aorta or the iliac artery. If the pain is in the calf, you usually look to the superior or superficial femoral artery or the popliteal artery. The time of activity to pain onset and the time to pain resolution are very predictable. Initial claudication distance is defined as the distance walked to the onset of the leg discomfort, while absolute claudication distance is the maximal distance that the patient can walk without stopping because of leg discomfort. This table is lifted from the European Society of Cardiology, showing both the Fontan and Rutherford classification for PAD. These are actually clinical stages of lower extremity artery disease, and both of them use symptomatology as their basis for classification from the earliest stages of stage 1 or grade 1 in both the classifications labeled as asymptomatic until the highest stages or highest grades, accounting to, of course, the loss or major tissue loss as well as the presence of ulceration or gangrene. So these are the approaches to the assessment and management of PAD in patients with diabetes. We utilize, of course, history and physical examination as well as various techniques for investigation. We first ask, of course, the patient's occupation. We examine his shoe wear. We investigate his foot care practices. We can do some gait tests We also utilize Berger's test or a modified pull test, which we will discuss in a bit. We examine the pulses and then check the sensation. We look for evidences of velocity, as well as we look for deformities or foot arch, type of foot arch, or some also check for gastrocnemius tightness. No? Other investigations we use include your ankle brachial index, your toe brachial index. We make use, of course, of your arterial duplex scans as well as investigate its waveforms. And then we look at the transcutaneous oxygen pressure, which is actually a non-invasive method to quantify skin oxygenation. We use this particularly in advanced stages of arteriopathy, not very commonly used in our country. No? And then we also look at your or utilize your pressure mat. Critical limb ischemia is the most debilitating manifestation of peripheral arterial disease. Diabetes and smoking increase the risk of developing CLI, with diabetes being the cause of most non traumatic lower extremity amputations. Your critical limb ischemia occurs as a consequence of tissue ischemia at rest, and it manifests as foot pain, non-healing ulceration, or tissue gangrene. The pain is often severe, unremitting, and localized to the sacral portion of the foot or toes, notably at the site of ulceration or gangrene. Other symptoms include hyposthesia, cold intolerance, muscular weakness, and joint stiffness of the affected limb. It's otherwise known as your 6Ps: pain, pallor, poikilothermia, paresthesia, paralysis, as well as pulselessness. The following are the tests that can easily be done at bedside or at the clinic. So the first is your Berger's test or Berger's angle. It's the angle at which the leg has to be raised before it becomes pale while the patient is in a supine position. In a limb with a normal circulation, the toes and sole of the foot stay pink even while the limb is raised by 90 degrees. In an ischemic leg, elevation to 15 or 30 degrees for 30 to 60 seconds may cause pallor. In this example, when the foot is placed in a dependent position in a normal leg, the color is restored within 10 seconds, as occurred in the right foot in this picture. This is compared to the left foot, which is pathologic, as evidenced by persistent pallor and delayed reperfusion. The Berger's modified Bolt test is based on hydrostatic pressure measurement. No? So modified Berger's angle is the angle to which the leg has to be raised before the Doppler signal is attenuated. So your pole test measures the vertical height equivalent. No? So the ankle pole test is equivalent to about 77 centimeters in height, but using Pascal's law, it's equivalent to about 60 millimeters mercury perfusion pressure. The pole test can be used for perfusion pressure of up to 70 millimeters mercury. The SEMS-Weinstein monofilament examination is an examination that can detect the presence or loss of protective sensation. This photo demonstrates the correct usage of the SEMS-Weinstein monofilament to detect neuropathy and to determine if protective sensation is lost. The patient is made to be comfortable with his or her eyes closed, and then the monofilament buckles when the 10-gram of linear force is applied by the examiner for about 10 seconds. It measures actually the response to a touching sensation of the monofilament using a numerical quantity. So it tests positive when there is, of course, a loss of sensation, or when the sensation is not detected by the patient. The silver skull test is commonly used to identify isolated gastrocnemius contractures. This measures the dorsiflexion of the foot at the ankle joint with the knee extended and flexed to 90 degrees. The test is considered positive when dorsiflexion at the ankle joint is greater than is greater rather with the knee flexed than extended. This table is from the New England Journal of Medicine, which differentiates and compares arterial ulcers from venous, neuropathic, and pressure ulcers. Take note that the arterial ulcers are circumscribed, tender, and prone to infection. The base of the ulcer is usually pale and are dry and may be covered by an eschar. The devitalized tissue is prone to infection, which may generate a purulent exudate, but in the absence of infection, gangrene may be dry and mummified. As mentioned earlier, in patients with diabetes, a thorough history and physical examination will frequently identify patients with PAD risk factors or pre-existing PAD. However, symptoms of leg pain, the development of ulcers, and functional impairments can be due to PAD or can be manifestations of diabetic neuropathy and should therefore be differentiated. Measurement of the ankle brachial index or ABI is a simple method employed to corroborate the historical and physical findings of PAD. This is actually a very simple test that can be utilized both at bedside or at the clinic. The ABI is the ratio of the systolic blood pressure at the ankle and brachial artery. ABI provides prognostic information because it is a gauge of the burden of systemic atherosclerosis. In the ABI collaboration, the incidence of advanced events rose as the ABI dropped below 1, even in the absence of symptoms. The lower ABI, or rather the lower the ABI, the greater the cardiovascular morbidity and mortality. An ABI of 0.8 or less is associated with twice the age-adjusted 10-year mortality, and an ABI of 0.4 or less is associated with a fourfold increase in mortality. Measuring the ABI provides an assessment of both PAD and cardiovascular risk. The ABI is the ratio of the systolic blood pressure at the ankle and the brachial artery, as I've mentioned, wherein the brachial is an estimation of your central aortic pressure. Brachial artery systolic pressure is measured in both arms and ankles using a handheld 5 or 10 megahertz Doppler ultrasound device and a sphygmomanometric cuff. The cuffs are placed on each arm above the antecubital fossa and above each ankle. The cuffs are sequentially inflated above systolic pressure and then are slowly depressurized. The Doppler probe placed over the brachial artery and the dorsalis pedis and posterior tibial arteries monitors the pressure. As the cuff is slowly deflated, reappearance of a Doppler signal indicates the systolic pressure at the level of the cuff. Brachial artery pressures must be measured in both arms because atherosclerosis may occur in the subclavian and axillary arteries. The higher of the two brachial systolic pressures is used for reference in the ABI circulation. Hence, the ABI is the systolic pressure at each ankle divided by the higher pressure of the two brachial artery pressures. An ABI may be generated for each leg. When assessing the foot perfusion, the ABI uses the highest of the pedal pressures in each leg. Both pedal pressures, both the dorsalis pedis the posterior tibial artery are considered when seeking evidence of atherosclerosis. Normal systolic pressure at the ankle should be at least the same as in the arm, yielding an ABI of 1 or greater. As a result of reflected arterial pressure waves Healthy persons tend to have an ABI ranging from 1 to 1.4. Recognizing an intrinsic up to 10% variability of blood pressure when measured sequentially, since arterial or ankle pressures rather are not measured simultaneously, an abnormal ABI consistent with the diagnosis of PAD is categorized as zero point 0.9 or less, whereas an ABI above zero point 0.9 to 1 is borderline abnormal. The ABI is a reliable determinant of PAD with a sensitivity of zero point 0.9 or less ranging from 79 to 95%, with a specificity of 98 to 100%. An ABI of zero point 0.4 or less is extremely abnormal and typically present in patients with critical limb ischemia, or CLI. Arterial calcification may introduce a false elevation with ABI, typically more than 1.4, as a result of non-comprehensible vessels at the ankle. Arterial calcification occurs most commonly in patients with diabetes or end-stage renal disease and in the elderly. This table actually that we placed on the right is taken from the latest Philippine Society of Vascular Medicine guidelines. This is 2019 to 2021 guidelines. Despite what has been said about ABI, a high sensitivity and specificity, it also has its limitations. Correlation between ABI, functional capacity, and symptoms are actually poor. Occasionally, it may turn out to be normal in patients with PAD, aortoiliac stenosis, as well as collateralized or well-collateralized arterial system. In patients with normal or borderline ABI but a strong suspicion of significant PAD, office-based exercise testing may be performed. The explanation behind this is that exercise will actually accentuate the arterial gradients by increasing the turbulence in the flow-limiting lesion, decreasing the muscular arteriolar resistance. To confirm the presence of occlusion in the arteries, there are several diagnostic exams, both anatomic and physiologic, that are available. Physiologic tests are useful to confirm the presence of a flow-limiting lesion, and this test can often indicate the involved vascular segment. This includes segmental arterial pressure measurement and volume plethysmography. The segmental pneumatic plethysmography, or PPG, determines the relative change in the limb volume with each pulse. This answers the question whether there is a hemodynamically significant arterial obstruction in a major artery. If the digits are symptomatic, PPG should be obtained on all digits as well. This is done by placing the BP cuffs at the mid portion of the upper arm and forearm, or thighs and lower legs, and PVR waveform recordings are taken at both levels. Then, the systolic blood pressure is measured at both levels using the appearance of an audible Doppler signal during the release of the respective blood pressure cuffs. In a normal and healthy individual, the blood pressure should be similar side to side and from one level to the other. Normal digital PPG waveform has a rapid upstroke, a downstroke that bows towards the baseline, a dichrotic notch, and a normal amplitude. Abnormal waveforms are blunted, rounded, or absent. Let's look at this example. So there is a significant pressure drop in the left arm to the left thigh, which suggests that there may be a stenosis in the iliofemoral segment. If you will also look, the pulse volume recordings are abnormal on the left. Again, a normal pulse volume recording has a sharp upstroke, then a downstroke with a dichrotic notch, or simply similar to an aortic waveform. The right has normal pressures and PVRs. Hemodynamically significant stenosis in the left iliofemoral segment, mild to moderate limb disease in the left lower extremity, but you have a normal ABI and normal ABI right lower extremity. That's how this is signed out. So, anatomical imaging of the peripheral circulation. So let's go to this. No? So defining the anatomy is not necessary in making the diagnosis of PAD, but this is required for patients who will undergo revascularization. So historically, catheter contrast arteriography has been a definitive or the definitive examination for lower extremity arterial disease. But this is invasive and expensive and is thus poorly suited for screening or long-term surveillance. Another limitation of an angiogram is that this only provides an anatomic information. Ultrasound assessment with duplex scanning extends the capabilities of indirect testing by obtaining anatomic and physiologic information directly from sites of arterial disease. A standard duplex ultrasound system uses high-resolution B-mode imaging, pulse Doppler spectral waveform analysis, and color flow Doppler imaging, which are adequate for scanning lower extremity arteries, and these accurately identify the location and severity of the disease. No? So, pulse Doppler spectral waveforms are best obtained in a long axis view or your longitudinal plane of the aorta. But transverse B mode image are views that are useful to define anatomic relationships, to identify branch vessels, to measure arterial diameters, and to assess the cross-sectional features of the aorta. So actually, this is an example of B-mode image or grayscale image, color Doppler, and spectral waveforms. These are actually very commonly used. The next couple of slides I will share with you will be your 2016 American Heart Association, American College of Cardiology guidelines on the management of patients with lower extremity or peripheral artery disease, the executive summary, which isn't really very different from the 2017 ESC guidelines on the diagnosis and treatment of PAD in collaboration with the European Society for Vascular Surgery. I would just like to emphasize the role of ABI. ABI with or without segmental pressures and waveforms has a class 1 recommendation in those patients that have a history and physical examination that are suggestive of PAD. This is true for both your AHA and your ESC guidelines. Your toe brachial index or your TBI is measured if patients are suspected to have PAD and have an ABI that is greater than 1.4. Exercise treadmill ABI testing is also used in patients with normal or borderline ABI and yet are symptomatic. So there are limitations to the use of duplex ultrasonography, and they include it being less accurate at the site of calcified plaque due to acoustic shadowing by the dense calcium. And it also has some difficulty in diagnosing serial stenosis because it relies on comparing peak arterial velocities between adjacent segments. However, it is important to remember that duplex ultrasonography may be used alone in planning percutaneous and surgical peripheral revascularization. How about exercise or treadmill exercise testing? This is done if ABI result is not compatible with the symptoms. This will let you see the true picture as exercise will increase the flow through the lesion and decrease the energy delivered beyond the area of stenosis and increases the severity of the ABI. If the ankle pressures, ABI, and Doppler waveforms recorded at the ankle level are normal, but the patient presents with symptoms consistent with intermittent claudication, the next step would be constant load treadmill exercise testing with post-exercise ankle pressure measurements. Your MRA or magnetic resonance angiography is an accurate imaging modality to diagnose PAD, visualize peripheral arteries, and determine the location of stenosis. This is actually performed with contrast, and it is useful as a non-invasive imaging test to define lower extremity vascular anatomy. MRA can identify the presence of stenosis and reveal distal vessels suitable for bypass, which is not demonstrated by contrast angiography. One potential limitation is the tendency for MRA to overestimate lesion severity. In the example, the Doppler shows that the common femoral artery has a moderate elevation in PSV at 186 centimeters per second, and on MRA shows that true enough, there is a stenosis in the origin of the common femoral artery. MRA has a sensitivity as high as 91% for the identification of arterial bypass graft stenosis, but overestimates lesion severity in up to 30% of stenosis. Your CT angiography has a wide application because basically any arterial bed that can be studied by arteriography can also be examined by your CT angiography. The limitations, however, include arterial calcifications, which hinders visualization of luminal patency, especially in the leg. And there's also difficulty visualizing segments which diameters are smaller than 1 to 2 millimeters. As your resolution improves, your CTA may become a regular instrument in the diagnostics because of its rapid study time, typically less than a minute, or because of the 75% reduction in ionizing radiation compared with angiography. In this picture, actually in the first picture, this shows an abnormal abdominal CTA with a runoff. The image shows bilateral common iliac aneurysms with distal runoff disease of the right lower extremity. In the second picture, there is diffuse atherosclerosis of arteries with a good single leg runoff of the right leg, which is your peroneal artery, shown by the arrow. And picture B actually is the right external iliac artery. The arrow shows the stenosis with bilateral renal artery, celiac, and superior mesenteric artery stenosis, which is shown by the thin arrow. And your picture C shows your right femoral popliteal artery stenosis, the top arrow, and stenosis at the tibioperoneal trunk, which is the thin arrow below. How about contrast angiography? It's the most useful and widely available method for imaging of the arterial anatomy. Despite wide acceptance of angiography as a reliable method for defining arterial anatomy, its invasive nature, requirement for contrast, nephrotoxicity, risk of atheroembolism, and risk of pseudoaneurysms or AV fistulas continue to foster the development of alternative angiographic methods. In this example, you can see the stenosis in your superficial femoral artery or your SFA. So, when revascularization is being considered, requests for a duplex ultrasound, MRA, or CTA to diagnose the anatomic location and severity in symptomatic patients. Invasive angiography is reserved in patients being considered for revascularization. These procedures, except for duplex ultrasound, are not recommended to check for anatomic assessment in asymptomatic patients. So finally, we end with these algorithms. No? So this is the diagnostic algorithm in patients suspected to have PAD. This emphasizes the role of ABI in diagnosing patients with suspected PAD. Segmental pressures and waveforms can be utilized, Also emphasizes that asymptomatic patients should not be subjected to unnecessary invasive or non-invasive anatomic tests. Also included is exercise ABI, which is utilized if the patient is symptomatic and yet ABI is normal or borderline. So we'll go through it quickly. So history and PE suggestive of PAD without rest pain, non-healing wound or gangrene. You do your ABI with or without segmental limb pressures. That's a class 1 indication. If your ABI result is greater than 1.4 in non-comprehensible arteries, then you do your TBI, or toe brachial indices, which is class 1. If it's normal, then you search for an alternative diagnosis. If it's abnormal, that means your TBI is less than 0.7. You should have lifestyle, and you have lifestyle limiting claudication. Despite guideline-directed medical therapy, you consider revascularization. If you do, then your options include your duplex ultrasound or your CTA or MRA as class 1 anatomic assessment, as we've discussed earlier. And you can also go through an anatomic assessment by invasive angiography, which is a class 2A level of evidence. And or you can continue guideline-directed medical management if you are not going through any form of invasive management. If your ABIs, however, are normal or borderline abnormal, then you can check for exertional non-joint related leg symptoms. If you do have, then you proceed to an exercise ABI, depending on whether it's abnormal or normal. And if it's normal, you search for alternative diagnosis. And if your exercise ABI is abnormal, you proceed to your anatomic assessments, just like the first arm of our algorithm, wherein our patients had abnormal TBIs. And if they are outright abnormal ABIs at the beginning, then you can go through an exercise ABI, which is a class 2A, or you can try guideline-directed management and follow again the right arm of the algorithm. As we said, that it is important to remember that you do not perform invasive or non-invasive anatomic assessments for asymptomatic patients. So the crux here would be, of course, your lifestyle limiting claudication despite medical management. And finally, for those with suspected critical limb ischemia, this algorithm is for patients who are suspected to have CLI, or for those whose history and PE fits that of CLI, particularly those with rest pain, non-healing wounds, or gangrene. So even in CLI, your ABI is the cornerstone in diagnosis rather. So it starts again, of course, with your history and physical exam. And if it's suggestive of PAD with rest pain, non-healing wounds, or gangrene, if you do, then of course, it starts all with an ABI. And that's a class 1 indication. Depending again on the results of your ABI, if it's greater than 1.4, then you do proceed with a TBI. And if it is abnormal, you go through a perfusion assessment. You can do TBI with waveforms, or you can also do transcutaneous oxygenation, or measurement of your transcutaneous oxygen pressure, or do skin perfusion pressure tests. If they are abnormal, then you proceed to anatomic assessment either by duplex ultrasound, CTA, or MRA, or invasive angiography. If it's normal, of course, you search for alternative diagnosis. If your ABI is normal or borderline, and you have the presence of a non-healing wound or gangrene, then you go through your perfusion assessment. If not, then again, you search for an alternative diagnosis. And if your ABI is outright abnormal, you add perfusion assessments, particularly if your ABI is greater than 0.7, you do your TBI with waveforms, your transcutaneous pressure, transcutaneous oxygen pressure determination, or skin perfusion pressure determinations. If they're abnormal, then you proceed with your anatomic assessment as directed for the other algorithms for grossly abnormal tests. And of course, if they're normal, you check for alternative diagnosis. I think that ends this lecture. I think I'm exactly on time, and I'd like to thank you for your attention. I'd like to make special mention of our vascular fellow, Dr. Marion Lagmay, who has very kindly put all these slides together for us this afternoon. Thank you very much.
Maraming salamat, Dr. Allen. Ate, salamat ng marami. We learned a lot again after that lecture. That voluminous information will hopefully be available for our review. Ginagawa namin, pagka meron kaming gustong balikan, we make it available on demand for the members ng PSD para ma-review namin. Kasi pag hindi pina-practice, nagdi-dissipate yung information, nakakalimutan namin. And it is only now that I realized that there are so many tests na pala. Ang dami-dami na palang test para sa PAD. May konting questions dito. And I promise you that you will be able to attend to your next assignment. Alam ko marami kang mga assignments. Busy ka eh. And you see, with the presence of the pandemic, yung COVID, ang daming ayaw pumunta sa ospital. Yung ibang pasyente pupunta sa ospital, puputulin na talaga yung paa. Yung paa, hindi mo pupunta kasi natatakot sa COVID. May isang nagtanong sa amin, no? Ito yata nakasulat dito, no? Nagtatanong na pwede bang gawin yung ABI ng pasyente sa bahay? Can they do that? Especially when they have an Omron sphygmomanometer na automatic. Kakabit niya sa arm niya, pagtas kakabit niya sa paa niya, tapos kukunin niya yung ratio. Pwede ba yun para hindi na pupunta sa ospital?
Actually, pwede kuya, no? I think it's a very practical test. Although, syempre, kung medyo duda ka sa pandinig mo a bit, no? That will probably be the only limitation, no? Because as we said, kapag gross naman yung difference, no? So kukunin nyo maybe twice yung determination sa brachial dun sa upper arm, like the way we do with our blood pressure. Parang kumukuha lang tayo ng BP. Ang medyo tricky yung sa paa kasi hindi tayo sanay talaga makarinig ng pulso sa lower extremity, no? Pero kung maganda yung stethoscope mo, okay pa yung pandinig mo, then at least for screening, just to give you an idea, no? Kasi kapag kukunin nyo also twice sa lower extremity, then of course you will compute by the equation that I showed you kanina, yung higher ng lower, nung right ankle pressure or at left ankle pressure, yung pinakamataas dun sa 2 o 3 beses yung ulit-ulitin para makasiguro, i-compute nyo divided by the higher pressure of the brachial, just like taking your blood pressure. And then and then of course you get that ratio, And then based on the levels that we said, wag na rin masyadong importante yung pataas ng 1.4 unless super taas, no? But usually, madali naman tandaan, 1 is the cutoff. 0.8 is already positive. Borderline ang 0.91 hanggang 0.99, 1 is normal. Pag less than 0.8, abnormal. Pag 0.4, severe na, actually. And that will already indicate that you probably need to ask for help na medyo totoo na yung simptomas ng pasyente. And screening na yun lang naman talagang importante. Actually, marami na akong palamuti na nasabi sa lecture para lang malaman natin na maraming other avenues. A lot of that we don't really use that practically anymore, no? The others are just to rule out muscular problems. But I had to mention it para lang kompleto yung picture, no? Katulad kunyari nung Weinstein, nung panahon namin si tatay mismo ko nakitaan, horsehair ang ginagamit. And there was no Weinstein at that time. There was no label for it. But I remember Dr. Panelo and tatay using filaments just to check on these patients in ISDF. I was a young resident at that time, no? But now there are graduated filaments to be used, and I just wanted to share that with our audience, no? Kasi kahit ako hindi ko na rin nagagamit critical care ako, hindi talaga ako masyadong vascular, but I started with vascular fellowship. So nakita ko rin mag-evolve itong mga tests na ito. No? So I diverted a little bit, but opo, you can definitely use an ABI at home for screening if you don't want to bring your patients. And if you see a significant difference, then that's when we can advise our patient more confidently that there is indeed a significant arterial problem.
Thank you very much. Ang dami namin natutunan, iba't ibang mga tests this evening. And thank you also for emphasizing the role of the ABI. Kahit na luma-luma na siya, very important pa rin siya. And thank you for stressing that it can be done at home. At ituturo namin yan sa aming mga diabetes educators and probably come up with a small survey kung how good it would be. At maybe, kung makakagawa kami ng survey niyan, ikukwento rin namin sa inyo kung ano makikita namin. We'll share information. And wala nang ibang mga tanong dito, kaya magpapasalamat na ako sa iyo. Thank you very much for giving us this time, sharing us your talents. Walang katumbas yun.
It's my pleasure, Kuya. Anytime for you at sa PSDM, of course. PSD pala. Wala palang M.
Dala namin sa yung yung iyong yung plaque of appreciation. Hindi pa namin, yes, namin, lalamove or grab.
Wow. Okay nga, picturean ninyo. Huwag na tayo masyadong toxic. Maraming salamat. It's good to see you and friends in the audience. No?
Thank you very much.
It was my pleasure. Thank you. Good night.
Good night. Bye-bye. I would like to call yung iba pang board of board ng PSD. Nandiyan ba sila Dr. Marcy Cruz, Dr. Dani?
Yes. Yes, Kuya. Yes, Kuya.
Yes. Meron ba kayong special announcement for tonight?
Let's call on Dani. Dani, are you there?
Nagpunta sa CR.
Oh, ikaw na, Kuya.
Oh, meron pa. Ay, kung wala na tayong ibang announcements, meron pa ba tayong isang session next time?
Yeah, we have our last session sa December, no? It's the dental DM, the regular dental diseases for diabetes.
Maganda yun. Siguro tatanungin din natin yung mga magle-lecture kung paano magbigay ng dental clearance. Di ba humihingi yung mga dentist ng dental clearance kung paano natin sila i-clear. So
pero ang ating guest, Kuya, Dentist.
Dentist? I
Yeah,
see.
she's a dentist.
Edi,
Common problem in diabetes.
dentist. Edi, tanungin natin yung moderator.
Okay.
Moderator naman.
Okay.
Diabetologist yung moderator.
Okay, Kuya.
Oo,
So we
okay.
would like to invite everyone for our upcoming yun ang last nating PSD 3 on December 4, 2021. So yan yung last, Kuya.
Okay, very good. And I would like to invite everybody to make comments. Good and bad comments, kailangan namin yun. Yung good comments, thank you very much. Pero mas thank you sa mga bad comments. Yung bad comments, yun talagang makakatulong sa ating mag-improve. At hanapin nyo yung points na pwede pa natin dagdagan. We need your inputs on what topics for next year. Marami tayong time para mag-prepare for next year. Pero maganda ituloy ito sinimulan ng board, sinimulan ni Kuya Dan na PSD Select. So I would like to thank everyone who joined us. Thank you again. Lagi kayong magpapakabait